Hello, my name is Dr. Michelle Gilliard. I am one of the lead speech language pathologists, and I will be having a discussion with you today regarding unique mealtime needs. Unique mealtime needs are often complex and challenging. Meeting students' unique mealtime needs requires a team. So, we are going to discuss today local teams as well as the school based team who are student focused, safe, and provides a compliant, unique mealtime needs process and practices that are planned, implemented, monitored, and continuously improved. So, we're going to discuss how we address mealtime needs within a multi tiered system of support similar to how we address academic concerns. Our learning objectives today will be to review CMS's framework for addressing unique mealtime needs, to discuss members and their roles in addressing those needs, to increase knowledge about the signs of aspiration, and to learn safe feeding techniques. So, with the MTSS support for unique mealtime needs, that first tier, tier one, is for all students who require safe food handling procedures, the opportunities to socialize, the opportunities to learn routines and manners, and to be taught enforced and reinforced behavioral expectations. Then tier two, which is a supplemental targeted adjustments. This is where some students may need mealtime adjustments, which may consist of patterns to accommodate common conditions. They may need a quieter area to accommodate their sensory differences. They may need adult-led tables where they are taught social, emotional, and behavioral skills, or they may need to have an adjusted table or seat height for the earlier grades. Then the most intensive tier is tier three, the intensive interventions. This is where a few students may need mealtime intensive interventions, which may be embedded or explicit social, emotional, or behavioral instruction. It could be separate setting or low stimulation settings. It could be extended time or adjusted routines for their eating. It could be where they require adapted physical setup, whether it's seating or utensils, which we will discuss. And it can be adapted or modified food, which includes the ingredients or the texture that may be needed. So, mealtime challenges, the prevalence and impact. I want us all to realize that unique mealtime needs are everywhere. Thus, that is why we are having this discussion today to make sure that we have a systematic plan in place to address our students' needs. So, our Dietary Modification Advisory Team, which is also referred to as DMAT, is a district level multidisciplinary team. It provides the district policies for students with unique mealtime needs, and it also resolves concerns and questions regarding special meal provisions that can't be resolved at the school level. So on the DMAT team, it does include representatives from the following departments: school nutrition, exceptional children, school health, and pre-K through 12th grade support services. The participants may also include registered dietitians, speech language pathologists, physical therapists, occupational therapists, registered nurses, social workers, school nutrition administrators, exceptional children administrators, and the LEA Section 504 coordinators. We also have a school-based team. This is the Unique Mealtime School-Based Support Team. This team is also a multidisciplinary team, which includes many school team members. And those members consist of the school nurse, dietitians, cafeteria managers, school administrator, teacher assistants, the IEP or 504 teams, related support providers such as SLPs, which are speech language pathologists, OTs, which are occupational therapists, PTs, which are physical therapists, could even include bus drivers, front office staff, any member who notices or receives information about a student's feeding or mealtime needs. So we are a very collaborative team. So let's talk about each member and the role that they serve on our unique mealtime support team. All right, so the school nurse collaborates with the cafeteria at the beginning and throughout the entire school year regarding meal modifications. So that's always found on the diet order. They also contact the healthcare providers or parents as needed when they need additional information. They develop what's called an emergency action plan, that's the EAP, for students that have life-threatening conditions. And they communicate this EAP plan to everyone that needs to be involved. Next, we have the CMS dietitian and the cafeteria manager. The dietitian oversees those special requests that I mentioned that are placed on the diet order form. The cafeteria manager provides the appropriate mealtime modifications that were instructed by the dietitian, which many of the information that's received comes from the diet order. And they also collaborate with the team about what's on the diet order and again, those EAP plans. School administrator is also a part of the team. They ensure that the unique mealtime needs are implemented according to this diet order, and they establish the emergency and communication plans in the event of an adverse mealtime event, which could happen on campus or it could happen off campus on a school trip or when substitutes or people that aren't very familiar with those students are with them during a meal. Teacher, very instrumental team member. They collaborate with the cafeteria manager and the school nurse regarding, again, the diet order and the EAP plan. They make sure that everybody knows what's on those EAP plans, the emergency action plans. We'll talk about some of the conditions, but I'm thinking about those students that may have diabetes and they may have a certain action plan, emergency action plan in place. So it's very important that the teacher is aware and make sure that they share that information with everybody else that's on the team. So we also want to know that the substitute teachers and anybody coming into contact with them while they're eating are aware. The instructional assistants participate in training to make sure that they are aware of those special needs. Many times they may assist the student with setup when it's time to eat, or they may actually need to assist in feeding if the students are not able to eat independently. The IEP and the 504 teams, they actually have their meetings to discuss those unique mealtime needs. They also implement and document accommodations as needed. And again, they ensure that all appropriate staff are notified of the mealtime needs. So we all collaborate, and it is all of our responsibility to make sure that we all know how to address the unique mealtime needs. The speech language pathology department, I will refer to the speech language pathologists as SLPs. Their role is primarily consultative. So they facilitate and support family acquisition of any community-based evaluations, interventions. They collaborate with the nurse and all school team members. They also consult with the community-based providers. They're on the team to make sure that they are providing any training that's needed for safe feeding and swallowing. And we'll talk a little bit about that. Although they're not medical-based speech language pathologists, they are able to provide consultation or assist in getting the information that's needed to support the student that has difficulty with feeding, or sometimes they may need guidance with adaptive equipment, diet, food preparation, optimal positioning per that diet order that we mentioned. And they work very closely with occupational therapists and physical therapists to make sure that this happens. So again, occupational therapy, which I will refer to them as OT, occupational therapist, they provide evaluations, consultation, interventions, training, and other support for any team member to make sure that those unique mealtime needs are met. They are involved in establishing mealtime routines, making sure that they have safe eating habits, making sure that the environment is appropriate. Sometimes there's sensory issues, such as a noisy cafeteria, they're not correctly seated. So they're making recommendations there as well. They're involved in the biomedical and the motor skills, the seating and the positioning to make sure it's the most optimal situation for that student. And then they're also very instrumental in acquiring any equipment, adaptive equipment or supplies that are needed. They are too consultative in terms of working with community-based evaluations, consulting with the SLP and other team members as well. So that is the school-based team, and anybody else that is, working with those students and can bring information about these students, all are collaborative to make sure we meet their needs. And so this slide, feel free to take a snapshot or to actually go to it on the intranet. When you look at this as a flow chart, it literally walks you through the process or the procedure for students with unique mealtime needs. The note that we want you to know as teachers and anybody that's working closely with these students, the diet order form must be updated whenever there's a change in the diagnosis or the treatment. So the diet order form should be accurate at all times to make sure that we are meeting the students' needs accurately. And as you read through this, you can see that it literally guides you through all of the steps. The first step is it even shares, if you can see in parentheses, it says parents, guardians share information with the front office staff, teacher, or bus driver. Then our staff shares this information with the school nurse. And then it just walks you through what needs to happen and how the diet order is completed. So we wanted you to have that knowledge of how that happens. Now, let's have a discussion about common diagnoses and conditions that require students to possibly have unique mealtime needs. And so some of these conditions are diabetes, as I mentioned before. There's type A, there's type 2. There are different types of neuromuscular diseases. As you can see, seizures are pretty common. Traumatic brain injury, and you can read the others there. There's some cognitive diagnoses where autism is one that we frequently encounter. Intellectual disabilities and ADHD also may require students to have some unique mealtime needs. The allergies, and we're going to talk in a few minutes specifically about what allergies are, but they also can cause students to have unique mealtime needs. There's some genetic diagnoses such as cystic fibrosis. There's the trisomy 21. You can read the others that are there. The altered growth patterns with obesity and failure to thrive, their eating disorders that may impact their mealtime needs, as well as the multi-system impact diagnoses, and that's cancer and other cardiac diseases. So we wanted to make you aware of some of those conditions that can require the student to have a unique mealtime need. So next, food allergies. Want to take a few minutes to talk about food allergies or intolerances because they're really one of the top reported mealtime related condition. We see that a lot. So a food allergy is really considered a disability, and it occurs when an immune system sees a substance as harmful and it overreacts to it. Some of the items that our students frequently are allergic to may be peanuts, tree nuts, which could be almonds, walnuts, cashews. Seafood is one also that we see, including shellfish, and then dairy products such as milk or eggs. So, all of those are some that we see frequently, I would say. And these students with these severe allergies will need an emergency action plan, the EAP, which again, the nurse puts in place and makes sure that we all are aware for our students. The next significant area is dysphagia. That's another condition. It's caused by difficulty or inability to chew or swallow. It can be used as a medical diagnosis, but today we're looking at it as a sign or symptom. Dysphagia usually is a sign or symptom from aspiration, and that's where food or liquid enters the airway and not into the lung. I mean, the airway or the lungs, excuse me. We don't want it to go into the lungs or the airway. We want it to go in the stomach, but we're going to talk about that in a few minutes. And aspiration can occur before, during, or after a swallow. That's kind of important when we're looking at those signs and symptoms of things to look for. 60% of pneumonia deaths are related to aspiration. So we wanted to give you some risk factors for those dysphagia, which is a swallowing difficulty, to look for. So if they have oral or digestive muscle and or nerve dysfunction, if they have limited oral sensory processing, if they're not able to properly chew and move the food or liquid, it collects in their mouth, which can be a risk. Poor posture control, poor judgment, lethargy or low alertness, and any existence of some of those medical conditions that I mentioned earlier can be risk factors for swallowing difficulty. And why this is important is because, as I said, it can lead to aspiration. Aspiration is the passage of food or liquid into the airway and then into the lungs. And that's not where we want it to go. We want it to go into the esophagus and then into the stomach so that it can be digested. I will highlight here that school-based SOPs do not diagnose aspiration, but they may make safe feeding recommendations. So, what is aspiration? Again, as we said, it is very dangerous. And over time, it can lead to pneumonia, which can possibly cause death. Aspiration is diagnosed by a swallow study, which is performed by a physician and a medical speech language pathologist. They use a barium swallow, which is a radiological study of the pharynx and the esophagus up into the level of the stomach with a contrast, which is barium, so that you can see whether or not it's going into the lungs. And therefore, that's where they can actually aspirate before they swallow, during the swallow, or after the swallow. But a medical provider needs to do that. Aspiration also can result in dehydration, pneumonia, chronic lung disease, because all of that food particle is going into the lungs, and that's life-threatening. Also can result in choking, which we know is a lack of oxygen, and it is a life-threatening situation. We are prepared. We all know and are trained to do the Heimlich, but nobody wants to have to use that. So we want to be very careful with aspiration. So, what are those signs to watch for? Our students sometimes are arching or stiffening as they're aspirating. They tend to have a decreased alertness level, which causes the food to go down improperly. They can be irritable. They may refuse food or liquids. You hear a lot of coughing and gagging, excessive drooling, therefore the oral musculature is very weak. You may hear gurgling sounds. They're stuffy and congested because of the aspiration that has occurred. Sometimes they spit up or vomit. food particles, and they may have a negative change in their demeanor, whether they look like they're afraid, they become tearful, or they're grimacing. The liquids are more difficult to control due to the speed of the movement of the mouth, and it can go down the throat the wrong way. So, all of these things are, we want to be very careful while we're watching a student eat or if we're assisting. So, if the staff or you or I suggest or suspect signs of aspiration, what do you do? Contact the school nurse or the occupational therapist or the speech language pathologist, have them observe as well. They have additional training, so they may be able to see some things and agree with you as well. You want to inform the school administration and the parent if the concerns consist. If the concerns persist, you want to make sure that the school nurse knows so that he or she may be able to suggest to the parent that they're seen by the doctor. They may send a letter to the doctor, or they may contact or have the parent contact the doctor. So these are all things that needs to happen. So this last slide that I will share in our discussion today is one that I created. It's the safe feeding eating strategy recommendations. So these are aspiration precautions. There's 7 steps that I want to review today of things to look for and to be mindful of. So the first step is to make sure that they're seated at a 90-degree angle or as close to as possible. Second, you want to encourage that student to eat slowly, or if you're feeding them, you want to feed them slowly. You don't want to give them too much food to where there's bolus or the oral cavity has particles still left in it. So those bite sizes and those sip sizes should be small so that they can manage it and that it goes down well and in the right place, not into their airway, but into their stomach or esophagus, which leads to the stomach. They want to complete a swallow. Many times when they're having multiple bites and they're not swallowing it, then it's staying in the oral cavity. It's building up. You want to encourage them to alternate eating foods and then liquids. So you may give a couple of bites of whatever food item they have. Make sure that they're swallowing. So that's where the single swallow comes in. You see that they've swallowed. Then after 1 or 2 bites, then you may want to give them a sip of something to drink, which also clears the oral cavity so that nothing is left behind, so that aspiration can happen after the swallow. And here's something that many of us don't think about because we're social creatures. And so when we're eating and we're dining, we're talking and we're socializing. But for our students that are at risk for aspiration, do not engage them in talking. Let them focus on swallowing and eating and making sure everything is gone. Conversations can be held afterwards. Make sure that the student remains upright for 20 to 30 minutes. That just makes sure that all of the food, all of the liquid, everything that they have eaten, that they've digested, it's gone into the right place and they are well. Thank you for having this conversation with me today. This concludes part 1, and you will have a review of this again during part 2.